Welcome to the Deep Dive. Today we're tackling a subject that becomes surprisingly relevant when it touches your life. Percutaneous tubes, drains, and also something called enterocutaneous fistulas.
Right, ECFs. They sound complex, and they are.
Exactly. We've gathered a wealth of information really drawing from expert insights in wound care essentials, practice principles, specifically the chapter on tube, drain, and fistula management.
Yeah, it's a really solid resource.
Our goal today is to kind of break down the what, why, and how of these, well, increasingly common medical situations. We want to give you a clearer understanding of the core issues involved.
And what's really striking is just the sheer scope of the challenges here. I mean, we're talking about everything from fluid and electrolyte balance, which is super delicate, to protecting the skin.
The body's largest organ.
Precisely. And then you've got the constant risks of infection, plus the critical need for good nutrition. It really shows you how intricate things get when these pathways are involved.
It really does. So let's start with the basics. Tubes and drains. What exactly are these percutaneous devices? And why are they used so often now?
Okay, yeah, let's unpack that. A percutaneous tube is essentially it's a controlled access point made through the skin to get to an internal organ or space.
Like a deliberate pathway.
Exactly. And their uses, incredibly varied. Think drainage, getting rid of fluids or air that shouldn't be there.
Yeah.
Or decompression, like easing pressure in the gut.
Okay.
They can also be used for lavage, that's kind of like washing out an internal area, or delivering medications, fluids, right where they're needed.
Very targeted.
Very. And crucially, for nutritional support if someone can't eat normally. Plus, they can help manage symptoms, pain, even in palliative care for comfort.
Wow, that's a huge range. So how do the medical teams decide precisely where these tubes go? Sounds like placement is key.
Oh, absolutely. Placement is totally dependent on the specific condition being treated. Often it's guided by imaging, like CT scans or fluoroscopy.
Live X-ray, basically.
Yeah, kind of, yeah. Or using endoscopy scopes, or even during surgery itself. A classic example is putting in a surgical drain during an operation to stop fluid building up, prevent an abscess.
Right.
Or think about placing a feeding tube directly into the stomach using an endoscope.
Yeah.
Very precise way to get nutrition in.
I see. So it's a carefully planned thing, not just a quick insertion. When it comes to actually managing these tubes and drains, what are the absolute must-knows?
Okay, the most important thing. You need to understand the specifics of each tube. Its exact anatomical location, where is it in the body?
Okay.
What are the manufacturer's guidelines for care? That's critical. Does the patient's anatomy have any quirks that might affect stabilization?
Good point.
What's the tube's main job? And, maybe most importantly, is it actually working? Doing what it's supposed to?
Right. Is it functional?
Exactly. All those details are vital for managing it properly and heading off problems.
Okay, so it's really about knowing the individual device. Now, our source material mentions different categories, common types,
Right.
often named after the body part they connect to, right?
Yes, that naming convention, like tracheostomy for the trachea, is pretty helpful. And it's true, these devices are just becoming more and more common in healthcare. Which means it's absolutely crucial that hospitals, clinics, they have clear policies, standard procedures, and staff who are really competent in managing them.
Based on evidence, manufacturer guidelines.
Exactly, all grounded in current literature and what the makers recommend. So should we look at some of the common types you might encounter?
Yeah, let's do that. Let's start with tracheostomy tubes. We hear about those, but what's the essential thing we need to grasp?
Right, so a tracheostomy, it's basically a surgical opening, right?
Yeah.
In the front of the neck goes straight into the windpipe, the trachea.
Okay, and why would someone need that?
Well, lots of reasons. Maybe an airway blockage up top, or someone needs a ventilator long term. Also for swallowing issues, to keep things safe. Or after certain surgeries to protect the airway, the tube just keeps that opening clear.
And what's the main challenge with having one?
The big thing is it bypasses how we normally breathe. So you lose that natural warming and moistening of air.
Ah, right. Stuff our nose and throat usually do.
Exactly. And speech, too, because the air isn't going over the vocal cords in the same way.
So you need specialists involved.
Definitely. Speech therapists, respiratory therapists, they're key players in the care team.
Got it. And the tubes themselves, are they one size fits all?
Not at all. Yeah, they come in different sizes, different shapes, depends on the person's age, neck size. Even BMI can be a factor, needing specialized tubes sometimes.
Makes sense.
And keeping it secure, that's vital. You don't want it coming out accidentally or, aspiration, infection. Those are big risks.
How do you secure it then?
usually with special collars or ties, and dressings around the site often foam. Sometimes it might have silver in it if infection's a particular concern.
Okay.
But, and this is important, you have to be careful not to use loose weave gauze right at the opening. Big aspiration risk there. Someone could inhale fibers.
Oh, wow. Okay, so it's really about managing that artificial airway and its effects.
Exactly. You're replacing those natural functions, humidifying, filtering, communication. It takes a real team effort.
That makes perfect sense. What about esophagostomy tubes? They sound a bit less common.
They are, yeah, definitely less common. An esophagostomy is a surgical opening into the esophagus, usually after a section's been removed due to disease.
Okay.
The opening, the stoma, it's often flush with the skin, kind of on the side of the neck, and that can create tricky contours, uneven skin, plus the neck moves.
Which makes pouching difficult.
Very difficult. Leakage of esophageal contents is a risk, even developing a fistula, an abnormal connection. Pouching that area, it's tough.
So you need specialist help.
Absolutely. Often needs a wound, ostomy, and continence nurse, the WOC nurse. They're the experts. They might suggest things like moldable barriers, smaller pouches. Sometimes decompression tubes are added too for nausea or vomiting.
Okay, definitely sounds like a case for the WOC nurse. Now let's shift to biliary tubes. What's their main job?
Biliary tubes, they go into the liver or the bile duct. The main goal is to relieve blockages, stopping bile from flowing normally.
How are they put in?
Either during surgery or using fluoroscopy, that imaging technique we mentioned. There are different types: cholecystectomy tubes, percutaneous drains, T-tubes, even nasobiliary tubes going through the nose.
And managing them. What are the keys?
Key things are stability, making sure it doesn't get pulled out, containing and measuring the bile drainage accurately, good skin care around the tube site, and just monitoring the output.
What's the biggest challenge? Leakage?
Leakage is a big one, yeah. Bile can be really irritating to the skin, cause moisture damage. Sometimes using a urinary drainage bag with an adapter helps contain it better and stabilizes the tube.
Interesting.
And patients might need teaching on using leg bags, for mobility, and maybe when they need to flush the tube to keep it open. It's really about managing that bile flow and protecting the skin.
Got it. Protecting the skin seems to be a running theme.
It absolutely is.
Okay, next up, nephrostomy tubes. What do we need to know about those?
Nephrostomy tubes go into the kidney, specifically the renal pelvis. They're used when there's a blockage stopping urine from draining out normally.
So they drain urine externally.
Exactly. Through an incision in the flank, the side. They can be temporary or permanent. Inside the kidney, they usually have a curled and a pigtail to help hold them in place.
And outside?
Outside, there are bumpers on the skin for stability. And again, stability is absolutely crucial. If the tube moves, it can erode the site, cause urine leakage.
Are there special devices for that?
Yes, there are commercial stabilization devices made just for nephrostomy tubes. They're also used for other kidney procedures, putting in stents, removing stones, biopsies.
Okay, so all about kidney drainage. Now, a very common one. Indwelling urinary catheters, IUCs. What are the key points there?
Right. IUCs are Foley catheters, as many know them. Used for a few main reasons. Emptying the bladder after surgery, maybe managing urine if someone has a bad wound near the sacrum where urine would delay healing.
And sometimes for incontinence.
Sometimes, yeah, but it's really not the ideal long-term solution for just incontinence. The huge focus here is getting that catheter out as soon as possible.
Because of infection risk.
Exactly. To prevent COUTs, catheter-associated urinary tract infections. Huge issue in hospitals. If incontinence is the problem, referral to a continence specialist is the way to go.
Okay. What about the catheters themselves?
Different materials, latex, silicone, most have that double lumen design. One channel drains urine, the other inflates a small balloon at the tip inside the bladder to hold it there.
Right, the balloon.
And there's the end part for connecting the drainage bag and inflating that balloon. We always aim for the smallest size that works to minimize trauma.
And care.
Sterile technique for insertion, sterile technique when emptying the bag, daily cleaning around where the catheter enters the meatus, just soap and water. Keep the drainage system closed to stop bacteria getting in.
Does the balloon size matter much?
It can. Smaller balloons often allow better emptying. Larger ones might be used short-term after something like prostate surgery.
What else do you monitor for?
Leakage around the catheter could be a kink, maybe mucus or clots blocking it, or bladder spasms. And definitely watch for signs of a CAUTI fever, chills, pain.
And the main goal is?
Prompt removal. As soon as it's not clinically needed, it should come out.
Got it. CAUTI prevention is definitely paramount.
Oh.
Okay, let's switch gears to enteral feeding tubes. These are for nutrition when someone can't eat normally, right?
Precisely. Enteral feeding means using the gut. It's generally preferred over parenteral nutrition, that's IV nutrition, whenever the digestive system is working.
Why is that?
Using the gut helps keep the small intestine healthy, prevents atrophy of those little villi that absorb nutrients.
Makes sense. And how are these tubes placed?
Various ways, surgically, endoscopically, with X-ray guidance, or even just through the nose. The main types are nasogastric, NG, gastrostomy, G-tube, and digenostomy, J-tube.
Let's start with NG tubes. Nose to stomach. Seems simple, but what are the catches?
They are common, relatively easy to put in, but they're the least stable long-term option and carry a higher risk of aspiration stomach contents getting into the lungs.
Oof, that's serious.
It is. They're used for short-term feeding, maybe stomach decompression, giving meds. But if someone needs feeding long-term, you really should look at a more stable, direct tube.
Who else gets involved with NG tubes?
Speech therapy is crucial for assessing swallowing. Dietitians figure out the nutritional needs, and anyone inserting or checking these needs proper training.
How do you make sure it's in the right place? Stomach, not lungs.
That's critical. Careful measurement before insertion, using lubricant, maybe having the patient sip water if they can during insertion.
But how do you confirm placement?
Well, X-ray is the gold standard initially, but for ongoing checks, maybe ultrasound, sometimes direct visualization, listening for air in the stomach, and checking the pH of fluid withdrawn from the tube. Stomach contents are acidic.
Ah, the pH test.
Right. And stabilization devices, tape, special holders, absolutely essential to stop it getting pulled out.
Okay, so placement and stability are paramount with NGs.
Yeah.
What about gastrostomy tubes, G tubes? How are they different?
G-tubes go directly into the stomach through the abdominal wall. Placed surgically or by interventional radiology.
More direct.
Much more direct. There are even dual lumen ones that can decompress the stomach and feed into the small intestine, the jejunum, at the same time.
Wow. And management concerns? Similar.
Pretty similar core concerns. Keeping it stable, preventing aspiration, managing fluids, preventing clogs, watching for medication interactions, providing the right nutrition.
And the dietitian is key here, too.
Absolutely. Assessing needs, choosing the right formula, that's their expertise.
Then there are PEG tubes, percutaneous endoscopic gastrostomy. Where do they fit?
A PEG is just a type of G-tube, specifically placed using an endoscope.
Oh, okay.
Scope goes down the mouth into the stomach, helps guide the tube placement through a small cut in the belly wall. Very common for treating or preventing malnutrition, supporting wound healing.
How are they stabilized?
Usually with dumpers, one inside the stomach, one outside on the skin, holds it securely. If a tube doesn't have built-in bumpers, there are external stabilizers you can buy.
Now, you mentioned common problems with enteral feeding leakage and clogs. Can we talk about those?
Definitely. Leakage of stomach contents around the G-tube site is a big one. Causes that moisture-associated skin damage, irritation, risk of infection.
What causes the leakage?
Well, because the tube goes right through the stomach wall, the stomach's natural movement peristalsis can sometimes wiggle an unstabilized tube, maybe enlarge the opening over time.
So stabilization again.
Stabilization is key, helps prevent that movement, allows the opening to heal and contract if there is leakage.
Okay, and clogs. What causes those?
Several things. Formula interacting badly with meds, not flushing the tube enough after meds or feeds, sometimes using a tube that's just too narrow for a thick formula.
How do you prevent clogs?
Prevention is definitely best. Flush with water before and after meds, before and after feeds. Use liquid meds whenever possible.
What if you have to use a crushed pill?
Crush it super fine, dissolve it thoroughly in water, and always check with the pharmacist first. Some meds, like time-released ones, absolutely should not be crushed.
Good point. Hydration too.
Yes, regular water flushes help with hydration and keeping the tube clear.
What if it does clog?
First step, try gently flushing with warm water in a syringe. Maybe gentle agitation if that fails. There are special clogbuster products with pancreatic enzymes.
Sounds serious.
It can be. It's really important to have a spare tube on hand just in case a clog is impossible to clear or if the tube gets accidentally pulled out.
Especially with confused patients.
Exactly. So strategies like stabilizers, maybe covering garments, even low-profile button tubes can help prevent accidental removal.
Lots of practical tips there. Finally, in this category, jejunostomy tubes, J-tubes, when are they the choice?
J-tubes go directly into the jejunum that's part of the small intestine past the stomach, usually for long-term feeding.
Why bypass the stomach?
Often for patients at high risk of aspiration, maybe due to vomiting or reflux issues, or if there are problems with the esophagus, stomach, or the first part of the small intestine duodenum that make a G-tube impossible or unsafe.
And stabilization.
Same idea. Internal and external bumpers to keep them secure.
This has been incredibly thorough on the different types and their specific needs. It really highlights the variety. Now, the source material also stresses patient and family education. Why is that so vital here?
That's such an important point. Often patients and families are, well, unprepared for tubes and drains. They might expect an incision after surgery, sure, but seeing tubes, that can cause real anxiety.
The unknown is scary.
Exactly. So preparing them beforehand, explaining clearly why each tube is there, where it is, that can massively reduce anxiety. Makes them feel more informed, more prepared.
Helps them plan practical things too.
Absolutely, like what clothes might work, how daily activities might change, and crucially, reinforcing why stabilization is so important, preventing skin damage. Accidental removal, that message needs to get across clearly to both the patient and whoever is helping care for them.
Empowering them with knowledge.
That's the goal. It improves cooperation, reduces fear, improves overall well-being.
Makes total sense. Okay, let's broaden out again. What about general management principles that apply across most tubes and drains?
The absolute foundation is meticulous skin care around the tube, paratube skin care. That means daily checks.
Looking for what?
Any signs of skin breakdown, redness, warmth, swelling, pain, drainage, things that could signal infection or irritation. Also, any leakage from around the tube or that moisture-associated skin damage we keep mentioning.
What about right after insertion?
Initially, usually a dry, sterile dressing with a split or hole for the tube, a fenestrated dressing to absorb any minor ooze from the procedure.
And once it's healed?
Once the site is healed, no more drainage from the insertion itself than just daily cleansing. Mild soap and water around the tube is usually enough to keep it clean and healthy.
And always follow specific instructions.
Always. Follow the manufacturer's guidelines for that specific tube. They can vary, and follow your facility's policies and procedures too.
Documentation is key, I assume.
Absolutely vital. Note the specific product type, size, what care was given, how the patient responded, the condition of the tube and the skin, any interventions done.
It sounds like it needs a holistic view.
It does. You need to assess the whole patient, their anatomy, why they have the tube, to create a truly individualized plan.
And it's often a team effort.
Oh, definitely. Pharmacists for med advice, dietitians for nutrition, speech therapists for swallowing, WCE nurses for skin and pouching expertise, the doctor who placed it. It's collaborative.
What are the most common shared concerns?
Key themes are always stabilization, using the right products for skincare and dressings, preventing infection, ensuring nutrition if it's a feeding tube.
What about when patients go home with these?
Discharge planning is critical for long-term tubes. Safety at home, clear communication with home health, specific instructions on managing the tube, knowing when to call for help, any other care needs. It has to be comprehensive.
That really drives home the team approach. Our source material even have a patient scenario about managing multiple drains. Can you walk us through that one?
Sure. This is a patient with complications from pancreatitis and a colonic leak. They ended up with 2 abdominal drains.
And the problem was?
Both drains were leaking quite a bit of fluid. The skin around them was red, eroded, kind of swollen and waterlogged from the constant moisture. And because the 2 drains were really close together, it was super challenging to get a good pouching system on there to contain the drainage and protect the skin.
So what were the goals?
Main goals were stabilize both tubes up, contain the drainage reliably while still allowing access, accurately measure the output from each, and of course help that irritated skin heal.
And the solution involved a WCE nurse.
Yes, the WCE nurse recommended a 2-piece pouch system. The skin barrier part was made of CMC, that's carboxymethylcellulose, good for absorption and skin-friendly. They also used these gelatin-based moldable rings, sticky on both sides, and a pouch with a special tube access port.
How did they apply it all? It sounds complicated.
It was detailed. First, they prepped the pouch with the access port, then put a moldable ring around the first drain, stuck it down, applied the pouch faceplate over that ring to seal it, then carefully pulled the drain through the access port in the pouch.
Okay, one down. What about the second drain?
Similar idea for the second drain. A moldable ring around its base, then a separate pouch faceplate applied over that. They trimmed the adhesive collar on that second faceplate for a good fit around the drain.
And drainage.
The pouch itself was connected to a drainage bag, set up for gravity drainage, made it easy to empty and measure the output from both drains separately.
Wow, that's a really clever, practical solution for a tough situation.
Yeah.
Really shows the value of that specialized WCE expertise. So summing up tubes and drains, what's the absolute key takeaway?
The fundamental thing is, successful management hinges on really understanding the specific device you're dealing with, the patient's anatomy, why that tube or drain is there in the first place, and what complications could happen. And central to all of that, constant, careful attention to stabilization and meticulous protection of that paratube skin.
Great summary. Okay, solid foundation on tubes and drains. Now let's tackle the more complex, often more challenging topic. Enterocutaneous fistulas, ECFs. What exactly is an ECF?
Right, an ECF. It's basically an abnormal connection, an opening that forms between two body organs internally, and this is key for our discussion, between an internal organ, usually part of the digestive tract, and the skin surface.
So like a leak from the inside out.
Exactly.
Yeah.
It leads to uncontrolled leakage of bodily fluids, intestinal contents, for instance, right onto the skin. These are really serious complications, devastating for quality of life, potentially life-threatening. Managing them takes a true team effort.
They sound incredibly serious.
They really are. ECFs are a stark reminder of how delicate our internal barriers are. When they broke down like that, the mortality risk goes up significantly. It underscores why aggressive coordinated care is so urgent.
So it's an unintended escape route for internal contents.
Yeah.
How do medical teams usually name and assess them?
They're typically named based on where they start inside the organ of origin, like a colonic fistula starts in the colon and where they exit, often the skin. Assessment involves figuring out that exact pathway, looking at the type and amount of drainage, and checking the patient's overall health.
How common are ECFs?
Yeah.
And who's most at risk?
Thankfully, they're relatively uncommon, but they are serious when they happen. Spontaneous ones can occur in people with inflammatory bowel disease, like Crohn's,
Okay.
or a history of radiation therapy to the area, or certain GI cancers. In surgical patients, risks include poor blood supply to the surgery site, maybe poor suturing technique, bowel trauma during surgery, not enough bowel prep beforehand, or if the patient was malnourished going into the operation.
Are there things that can be done, especially around surgery, to lower the risk?
Yes, definitely. A proactive team approach helps. Managing underlying diseases like Crohn's well, making sure patients have good nutritional support before surgery to help healing, plenty of IV fluids, sometimes prophylactic antibiotics.
What about high-risk surgical sites?
If a site looks like it might heal poorly, the team might opt for secondary or tertiary intention, healing, letting it heal open gradually, or even creating a temporary ostomy to divert stool away from the area while it heals.
These sound like incredibly significant issues.
Yeah.
What are the outcomes typically like for patients with ECFs?
It's tough. Mortality rates can range anywhere from, say, 5.5% up to 30%. The big killers are infection, those fluid and electrolyte imbalances we mentioned, and poor nutrition.
Can they heal on their own?
Sometimes. If caught early and managed well supportively, some might close spontaneously, maybe over 4 to 6 weeks. But if not, surgery is usually needed to close it, but only after the patient is stabilized medically.
And recovery? Costs?
Recovery is often very long, and the cost of care is substantial. Think specialized supplies, diagnostic tests, tons of nursing and medical care, nutrition support, maybe multiple surgeries. It can run into hundreds of thousands of dollars potentially.
Wow.
But the good news is advances in nutrition, in containment devices for the drainage, in managing fluids and electrolytes, these have definitely improved outcomes over time.
That really highlights the gravity and the challenge. The source material mentions classifying ECFs. Why is that important?
Classification helps us understand the specific fistula better. It guides assessment, management planning, how we document progress. There are different ways to classify them by the type and amount of drainage, the anatomy of the tract, how complex it is.
Let's talk about the drainage amount. There are different levels.
Yes, output volume is critical. Low output is usually less than 200 milliliters in 24 hours. Moderate is 200 to 500 milliliters, and high output is over 500 milliliters in 24 hours.
And high output is tougher to manage.
Much tougher. Leads to rapid fluid and electrolyte loss. Needs more intensive support, more robust containment to protect the skin.
Are there other classifications?
We also talk about complicated fistulas may be associated with an abscess involving multiple organs, or if the opening is deep in a wound base, sometimes called an atmospheric fistula. Accurate, continuous output monitoring is absolutely essential for managing fluids.
And the type of drainage tells you something too.
Absolutely. Color, consistency, even pH give clues about where it's coming from in the gut.
Like what?
Gastric drainage from the stomach, usually clear, light yellow-green, watery, very acidic pH around 3. Bile drainage, thicker, gold to deep green, more neutral pH, maybe 7.5. Pancreatic, clear, watery, more alkaline, pH maybe 8.3.
And skin pH is much lower.
Right. Healthy skin is acidic, around 4.5 to 5.5. So you can see how drainage with a very different pH can cause major skin damage if it's not contained.
So managing an ECF isn't just stopping the leak. It's understanding the source and protecting the body from the drainage itself. What are the main goals of management?
It's a complex process. You need to diagnose the cause, the location accurately, and it demands that interdisciplinary team.
Who's typically on that team?
The surgeon, obviously. WOC nurses are crucial for products, containment, skincare, registered dietitians for nutrition and fluids, social services for psychosocial support. This is really hard on patients and families.
And care often spans different settings.
Often, yeah. Long-term care, maybe rehab, home. The primary goals are identify risk factors early, detect the fistula promptly if it forms, then coordinate care to tackle complications, nutrition, hydration, containment, infection.
What should teams watch for in at-risk patients after surgery?
Vigilance is key. Look for fever, swelling, skin hardening, or more tenderness near the site, increased pain, changes in electrolytes, altered mental status.
And if an ECF is suspected, tests.
Things like fistulograms, injecting dye to see the tract on X-ray, PET scans, MRI can give more detail.
We need to remember what's in that drainage.
Absolutely. Sodium, potassium, magnesium, zinc, proteins, digestive enzymes, lots of fluid. Losing all that has a massive impact on nutrition and electrolytes.
And the skin damage is from
both the pH difference and those digestive enzymes literally breaking down the skin. Exposes the dermis, increases infection risk, causes a lot of pain.
Might they even stop oral intake initially?
Sometimes, yes. May need to withhold everything by mouth at first to really assess things and start aggressive medical management.
That sounds like a very intensive, coordinated effort is non-negotiable. What does the typical medical management involve?
It really focuses on 4 main pillars. First, fix and maintain fluid and electrolyte balance that's often way off. Second, aggressive nutritional support to combat losses. Third, prevent and manage infection, a major cause of death. And fourth, accurately map out the fistula's location and extent to guide treatment.
Does early treatment help spontaneous closure?
Early, aggressive focus on those 4 goals optimizes the patient's condition and might increase the chance of spontaneous closure. But realistically, that only happens in maybe a third of cases.
So, often TPN initially. 5E nutrition.
Often, yes. Withholding oral intake and starting TPN is common at first, but as things stabilize, they might try to reintroduce oral or enteral feeding if possible. Helps keep the gut working. TPN might still be needed as a supplement, though.
What needs constant monitoring?
Blood sugar, electrolytes, weight, constantly watching and adjusting.
Are there medications to reduce output?
Sometimes. Drugs like octreotide or somatostatin are tried for high-output fistulas, but results are variable, unpredictable. If there's no clear improvement in 2-3 weeks, they're usually stopped.
And infection watchfulness.
Absolutely critical, nonstop. Sepsis is a huge risk, dramatically increases mortality. Looking for any sign fever, high heart rate, high white count, confusion.
So if it doesn't close on its own in, say, 6-8 weeks,
then surgical closure is usually considered. But some things make spontaneous closure unlikely: ongoing sepsis, severe malnutrition, a blockage further down the bowel, if the fistula tract has matured and lined itself with cells.
epithelialized.
Right, epithelialized. Or if there's exposed bowel lining at the opening, or if you just can't get high output down.
Is there anything like a glue for fistulas?
For some specific low output ones, yes. A biological glue made of fibrinogen and thrombin can be tried. Needs cleaning out first, often multiple injections.
When is surgical closure most successful?
Success is more likely with careful planning after the patient is optimized fluids, electrolytes, nutrition are good, infection and inflammation are under control. Reduces risks like peritonitis or new fistulas forming. Timing depends on the fistula anatomy and patient readiness if they're unstable. Medical management continues.
It sounds like a real tightrope walk between medical support and surgery. What about the nursing management side? What are the key considerations there?
Nursing care needs that holistic view, reviewing history, current situation, test results. Physical assessment, especially the skin around the fistula, psychosocial needs are huge, and discharge planning starts early.
What are the main nursing focus areas?
Meticulously tracking the amount and type of drainage, assessing and managing that parafistula skin that's paramount, infection prevention and early detection. and effective containment of the drainage.
Skincare sounds like the top priority.
It really is, because damaged skin makes everything harder, increases infection risk, makes pouching near impossible. WOC nurses are invaluable here with their product knowledge and understanding of abdominal contours.
What are the specific day-to-day nursing concerns?
Precise effluent measurement, odor control that can be a big quality of life issue, meticulous parafistulous skin management. Cost containment, these supplies are expensive, and thorough patient and caregiver education.
What kinds of products are used?
A whole range: ostomy pouches, solid barriers, pastes, powders, special wound pouches, catheter holders, tube access ports, odor control products, maybe even suction. Often it's a combination tailored to the patient and adjusted as things change.
What about low-output ECFs? Less complex.
If the output is really low, say under 100 milliliters a day, sometimes absorbent dressings are enough, maybe ones with charcoal for odor.
You've mentioned pouching a lot for ECFs. Why is getting a good pouching system so critical?
The main goals are contain that corrosive drainage, protect the surrounding skin and let it heal if it's damaged, and provide a moist healing environment if there's an open wound too.
But it sounds incredibly challenging sometimes.
Especially with high output or fistulas in the base of a deep wound. It can be really complex, often takes multiple people just to apply the pouch. You're dealing with high volume, maybe a large irregular area, skin that isn't level.
So what helps?
Using things like moldable solid barriers, barrier pastes or powders to fill gaps. Choosing the right size pouch with the right adhesive. Assessing the skin contours carefully, lying down and sitting up. Looking for scars, creases that could break the seal.
How do you deal with uneven contours?
Using paste or moldable rings to build up low spots, create a flatter surface. Sometimes cutting little slits or darts in the barrier opening gives it more flexibility around an irregular shape.
How close should the barrier opening be?
As close as possible to the fistula or wound edge without actually touching it. Any tiny bit of exposed skin nearby can be protected with barrier ointment. Wound pouches with windows are helpful for checking underneath without removing everything.
It sounds like it takes persistence.
It really does. Thorough assessment, trying different things, reassessing, problem solving. It's often trial and error.
And once you find something that works,
document everything. Clear step-by-step instructions, exact product list, maybe even a pattern or template. That helps consistency, handover, and also cost containment if you're not wasting supplies with failed attempts. Documenting wear time is also important for insurance.
it definitely sounds like both a science and an art. What about negative pressure wound therapy, NPWT? Does that have a role with fistulas?
It can in specific situations. NPWT uses suction through a special dressing to remove fluid, reduce swelling, and promote healing in a wound bed.
How would you use it with a fistula?
The idea would be to use NPWT on the wound part to help it heal, while carefully isolating the fistula itself and using a separate pouching system just for the fistula drainage. It's done concurrently.
Are there specific criteria?
Generally, it might be considered if the fistula seems likely to close spontaneously, isn't fully matured or lined, there's no exposed bowel in the wound, and no nearby abscesses.
Are there risks?
Safety is huge. The suction could potentially cause a new fistula if you're not careful, so you always use a protective layer, silicone mesh, petrolatum gauze between the fistula or delicate tissue and the NPWT sponge.
And proper training is essential.
Absolutely. Follow manufacturer guidelines, and nurses using it need specific competency, especially with fistulas.
Given all this complexity, the long timelines, the cost, case management sounds crucial.
Absolutely essential. Managing ECFs is expensive. Insurance coverage for supplies can be tricky. Patients often move between different levels of care, and the psychosocial impact is massive.
So case managers help coordinate.
Yes. Early involvement is key. They help with communication between all the teams, navigate insurance, figure out the best, most cost-effective care pathway, both in hospital and for discharge.
What do they consider when planning discharge or transfer?
Things like, is there a reliable pouching system that lasts at least 24 hours? If NPWT is used, can it be managed in the next setting? What are the skills of the providers there? What education is needed? How will supplies be obtained? Is insurance coverage confirmed? Lots to coordinate.
So wrapping up on ECFs, they're devastating, complex, high risk.
Absolutely. High risk for sepsis, malnutrition, electrolyte chaos, huge containment and odor issues, skin breakdown, high mortality. It all points to needing early identification, risk reduction, prompt symptom recognition.
And the goals remain.
Stabilize nutrition, fluids, electrolytes. Contain and monitor the output. manage odor, prevent and treat infection. Use that interdisciplinary team. Various wound and pouching options and PWT sometimes, but always a holistic approach.
The source even includes a really complex case study. Can you briefly touch on that?
Sure. It was a 64-year-old with advanced colon cancer, getting worse despite treatment. Very malnourished cachexia. Had an obstructing tumor they couldn't operate on, a colostomy already, anemia.
And then complications.
Yeah. Perforated viscus, a hole in an organ led to peritonitis, a bad abdominal infection, and ended up with 4 separate abdominal fistulas. A really challenging situation.
And the pouching challenge there.
The skin around all 4 fistulas was very red, irritated, broken down. The abdomen had uneven contours, making it incredibly hard to get a pouch to seal. Initial tries with standard convexity leaked really quickly, like within 15 hours.
So what was the final successful solution?
It involves several things. Moldable skin barrier seals to shape around the fistulas and even out the contours, skin cement for extra adhesion, a special wound manager pouch designed with multiple openings you can cut out.
So they cut openings for each fistula.
Exactly. Made a template first, put barrier paste right around each fistula opening, then the moldable seals, then carefully applied the multi-opening pouch over everything.
And the outcome?
That detailed approach finally gave them a seal that lasted about 48 hours. Huge improvement in comfort, contained the drainage and odor, and allowed the skin to start healing. Really shows the expert problem solving needed for these complex cases.
A powerful example. Okay, before we wrap up, the source has a few review questions. Let's run through them quickly. First, which is a definitive indicator of a fistula in an abdominal surgical wound? A, fever and erythema. B, wound drainage and dehiscence. C, gastrointestinal contents in the wound bed. D, abdominal pain and serosanguineous exudate.
Definitive indicator is C, finding actual GI contents in the wound. The others can be signs of problems, but seeing bowel contents confirms the connection.
Perfect. Second, optimal function of enteral feeding tubes depends on which primary nursing considerations? A, hydration location diagnosis. B, skincare, hydration location. C, tube stabilization, hydration, nutrition. D, nutrition location, continuum of care.
I'd go with C, tube stabilization. Ensuring adequate hydration and providing the right nutrition are all primary considerations for good function.
Right. Third, which condition predisposes a patient to ECF formation? A, normal nitrogen balance. B, albumin 4.0. C, blood glucose 80. D, Crohn's disease.
That would be D, Crohn's disease. It's a major risk factor for ECFs. The others are signs of relatively good health status.
Makes sense. And last one. Patient has a high-output ECF, 9,600 milliliters in 24 hours. Staff are worried about overflow and leaks. Best immediate advice. A, ditch the pouch, use gauze. B, connect pouch to gravity drainage. C, add more paste tape. D, restrict fluids.
Definitely B. Connect the pouch to a bedside gravity drainage system. With that much output, you need continuous drainage to prevent overflow, protect skin, and measure accurately. Restricting fluids might be necessary overall, but it's not the immediate fix for pouch overflow.
Excellent. That quick review really hammers home some key points. So bringing this all together, it's crystal clear that managing tubes, drains, and especially these complex ECS requires, well, a really deep understanding.
Understanding the purpose, the potential complications, the meticulous care strategies needed.
And the crucial role of that interdisciplinary team, proper stabilization, protecting the skin, vigilant monitoring, it all comes together.
The complexity of ECFs really highlights how vital early identification is, and that holistic approach, nutrition, fluids, electrolytes, skin, the whole picture.
So maybe a final thought for our listeners. Thinking about how common these situations are becoming and how complex medicine is getting, how might future advances, maybe in technology or even better team collaboration, further improve outcomes and quality of life for people facing these challenges?
That's a great question to ponder. We definitely encourage you to keep exploring the resources, stay updated on best practices. Wound care is always evolving.